It's a pleasure to finally present to the whole group. So I just want to start by going over what will be covered during this presentation. So I just want to cover a bit about some background and issues relating to the study. So discuss a little bit about acute HIV infection, window periods, and some trends that researchers have picked up upon with respect to onward transmission of HIV. I want to talk a bit about the study and just provide a bit of a description and overview and summarize the research, study, and protocol, and just a review of the current recruitment and experiences thus far. And then I also want to talk a bit about the lessons learned in the study. So what we've learned over the past 6 months since implementing the laboratory algorithm for the study, which included introduction of the nucleic acid amplification test, as well as the 4th generation antibody-antigen combination test, both of which can be used to detect acute HIV infection. So this slide just shows the awareness of serostatus among people with HIV and estimates of transmission. So what you see here is that people who are unaware of their infection are contributing disproportionately to new infections each year. It's important to note that these studies or these estimates are based on studies involving several populations and jurisdictions and may be different for gay men who have a relatively higher rate of HIV testing. So this slide just kind of breaks down the compartment for the main sources of HIV infection. So in addition to the impact of knowing one's status, the unique phases of HIV infection have different sets of implications for onward transmission. So for example, sources with early infection, the ones that we're trying to address through this study, these are occurring primarily because of the high viral loads that are associated with the acute phase of HIV infection. This phase occurs between the time of actually being infected with HIV and the completion of the seroconversion process, which is about 2 months. Recent or early infections past 2 months from infection are likely to still have higher than average viral loads as well. People who are in the acute phase are also more likely to be unaware of their status during this phase. Sources with chronic or established infections, generally these folks have lower viral loads and hence lower infectivity and a lower probability of transmitting the virus to other people. During this phase, people are also more likely to be aware of their status and can take behavioral measures to reduce transmission risk. Also, if they're on treatment, their viral loads will also fall, reducing their likelihood to pass on the virus. Sources with late infection, there's intermediate infectivity, higher viral loads than in the established phase of infection, but because generally people who are in this phase are quite sick and probably aren't having a lot of sex. So there's a lowered risk of transmitting the virus. So this poster is just an example of different efforts to try and detect and identify acute HIV infection before there were good tests available to actually do that. And so basically, it's discussing or kind of framing the issue in terms of acute HIV syndrome, basically looking for symptoms that would be indicative of acute HIV infection. Of course, this is not a foolproof method, and it's I think it's also problematic in the sense that many people who present themselves to clinics often have flu-like symptoms, and the clinician's probably first instinct is not that it's acute infection, but rather, it's more likely to be flu. Fortunately, though, we have tests now that can actually do this work so that people don't have to, look out for seroconversion illness or acute HIV infection syndrome. So this slide just shows basically from the time of actually getting the virus, which is where the green arrow is, for the first year of infection. And the bars, the horizontal bars are basically indicating what the window periods are. So the most common HIV tests are based on the detection of 3 biological markers of HIV infection. And those 3 are viral RNA, the P24 antigen, which is a viral core protein, and HIV-specific antibodies, which is the body's immune response to HIV. As you see there, the first generation antibody test had a window period of approximately 33 days versus the third generation test, which is standard in BC today and has a shorter window period of 22 days. This test has high sensitivity and is used as a screening test across BC. Any degree of reactivity leads to further tests, including a confirmatory test, such as the Western blot, as well as the nucleic acid amplification test to resolve indeterminate Western blots. Window period estimates are typically based on averages or statistical projections, and as such, they shouldn't be interpreted as an absolute cutoff, as individual variation does occur in the time to detect HIV. However, it's estimated that greater than 95% of individuals will show detectable antibodies to HIV by 4 to 6 weeks, with more than 99% seroconverting within 3 months. This has led to a change in the counseling guidelines for testing, which previously it was recommended that people get repeat testing at 6 months, and so now it's 3 months, and since it's been demonstrated that 99% or greater than 99% of people will have completed the seroconversion process by then. The 4th generation combo assay is basically the 3rd generation antibody test that combines the P24 antigen assay, which is just that pink line on the graph, which has a window period of 17 days. And then the last test to kind of take note on there is the HIV RNA test, or the nucleic acid amplification test, which actually tests for the virus itself, meaning it has a shorter window period because it doesn't have to wait for the body to produce antibodies to detect it. So again, the RNA test involves the amplification and detection of viral RNA as opposed to viral antigens or antibodies. And the purpose here is not to measure viral load, but to detect for HIV infection. It's widely used in blood transfusion services. The Canadian Blood Services uses it to test their blood. And the cost-effective use requires pooling, which basically means samples that test negative on the screening test, a portion of the serum that's collected is pooled together and is tested using the nucleic acid test that will basically, if there's any positive reading on a pooled tested sample, they'll divide up, or they'll resolve the pool by testing individual specimens using the nucleic acid amplification test. So finally, to the study. It's a 5-year grant funded by the Canadian Institutes for Health Research, and it's housed at the BC CDC to determine the feasibility and efficacy of using advanced testing technologies to identify and respond to acute HIV infection among gay men. We opened recruitment for the study in April of this year through the implementation of the laboratory algorithm at 4 strategic testing sites in Vancouver. Since then, we've added 2 sites, and we're planning for implementation at the Cook Street Clinic in Victoria. Just a few notes about that. when I say strategic, we utilize a targeted recruitment strategy. It's also an important cost-effective measure. I think one of the main reasons why it hasn't been implemented already is that it's more expensive to use than the standard screening test. And so part of the challenge was to find a way to make the testing methodology cost-effective. It's a very multidisciplinary team involving 3 sub-teams: a prevention, formative, and mathematical modeling team. The prevention team, there I'm including all the folks that are working in the labs, the clinics, as well as the research staff. The formative research is basically the research to inform the research. Olivier's presentation later today will go over his work with HIV-positive gay men on their needs at the time of diagnosis, which is really important in terms of informing the development of appropriate programs and services for newly diagnosed gay men. It's a longitudinal cohort study, and there are several areas in the study where there is a high degree of community collaboration. And that's particularly in the counseling aspect of the study, as well as for the social marketing and knowledge diffusion activities in terms of just getting information out there on the new tests and getting the word out there. So the study is eligible to males who are 19 years of age or older, and basically everyone who comes to our recruitment sites, they're listed up there: the BC-CDC, STI, and Beat Street clinics, Spectrum Health, Three Bridges, Dr. Richard Taylor's office, as well as the HIM Sexual Health Center. Anyone who presents themselves at one of these sites requesting an HIV test will be included into the advanced lab algorithm. I'll just flip over to the next slide just to show you what that looks like. Yeah, kind of complicated. In order to be included into the study, into the Q arm of the study, patients clients have to test negative or indeterminate on their ELISA test with a positive result on their NAT test. We're also more recently including men with recent infections, so that would be anyone with a positive test result with a no negative test result within the last 12 months. Just a bit about the study activities. There are quantitative and qualitative interviews that are completed. We also collect the results from the follow-up blood work that our participants do with their care providers, and we collect that alongside the other data. I mentioned before, we also include a peer and professional counseling component into the study. And Bill Coleman's workshop yesterday kind of is a bit about the model that we utilize in the study. To date, we've recruited 2 men in the Q arm and 1 man in the recent arm. So I just want to quickly talk about 3 critical steps in terms of setting up the recruitment for the study. So a lot of work went into the development of this algorithm, and I think there were 3 critical steps. It's broken down by the theoretical development of the algorithm, the laboratory implementation of this, and the pilot program implementation. So just in terms of the theoretical development, just figuring out how best to design the algorithm with respect to the lab implementation, working out the kinks, training the lab staff on the revised protocols, and for the program implementation, that was about the logistics between collecting the specimens, ensuring samples don't get missed on the pooled NAT test, and educating providers that this new test is being offered for them, and to revise their pre- and post-test counseling guidelines accordingly. So I guess how we're doing, I think what the experience to date has demonstrated that the lab algorithm is successful. Acute diagnoses have been made since we've implemented this algorithm. Our current challenge, I guess, is to raise awareness of the availability of these tests so that more people take up this test when after a risk event, as opposed to waiting the 3 months that they've been instructed to previously. In order to actually identify more people with acute infection, people will really need to change their testing practices more in line to how these tests are designed. Okay. Just 1 minute. Lessons learned. So again, our testing algorithm has shown to be successful, and it's been implemented at 6 sites. But again, we have low recruitment numbers, and I think possible explanations are that if people have been instructed to wait out the window period for 3 months and get tested, they're not even if we offer this new test, we're not going to be able to identify any new acutes that way. And so in order to really change that situation, we'll have to put a lot more effort into getting the word out and doing social marketing and working with our community partners to kind of ensure that gay guys out there know that there's a test out there that can actually detect for acute infection. Big team. And I just want to thank all these people. Clearly a huge amount of expertise that has gone into this study, and I'm appreciative of all their help and support.